Thank you for the lovely land acknowledgement, and thank you to those individuals who are joining us during their lunch hour. We have a more copious title to suggest for the presentation. It's called Beyond Intervention Effectiveness, Understanding Acceptability of Interventions to Successfully Implement Built Policy and Social Environmental Changes Aimed at Healthy Eating and Active Living. I promise you that the next slides will be a little bit less fulsome. The research that we're going to be reporting on was supported by the Canadian Institutes of Health Research, 2 grants, and we're very, very grateful for the support of the Urban Public Health in the conceptualization and dissemination of this research. They were our partner in terms of dissemination. And there are other members of the research team that allowed us to do the project, and they are named here, and I will not go through this list of names, but we can talk about that a little bit later if that's of interest. What we'd like to do is to introduce the audience to why we're talking about acceptability of built social and policy changes in environments and why we think that's important. We're going to share the results of a survey that we conducted. And most importantly, we'd like to gain some of your perspectives on what this might mean for the practice and for research in public health. In terms of an introduction, I'd like to say that why did we start to study intervention acceptability? Well, it's probably not a secret to anyone around the table that healthy eating and physical activity are critical to chronic disease prevention, and they have many, many health benefits, both for populations as well as for the environment. Yet we do know that many Canadians do not meet recommendations, and that individuals with lower income and education are even less likely to meet recommendations. So now there's a growing body of research that suggests that policy-built and social environment changes are more likely to contribute to healthy eating and physical activity than interventions aimed at knowledge, beliefs, and attitudes, or simply acting on individuals. And so first and foremost, what we do want to say is that these interventions, most of the research is focused on effectiveness and whether if you do make some of these changes, whether there will be changes in physical activity and healthy eating. But beyond effectiveness, to be able to change policy, built and social environment requires appropriate implementation considerations, including, of course, effectiveness. It has to be implemented at a large enough scale. There has to be the appropriate financial and human resources to do a good job of making these transformations. But it's also important to have population level of acceptability. And the reason for that is that if there's not a population level of acceptability, implementation will be difficult. And even if implementation is possible, it is likely that there might be resistance to using some of the new resources that are available in environments. And so we decided to study acceptability. Of course, first questions that academics are going to ask is, what is acceptability? And acceptability has 2 connotations at least. One of them, which is at the individual level, and another one that's at the collective level. At the individual level, acceptability refers to a cognitive expression, either agreement with, support of, or with or without some affective dimension. That is, people are favorable towards something. In this case, it's a change in built policy or social environments. And it can be thought of as a collective construct as well. That is, the proportion of individuals in a given area or within a given population who agree with, who support, or who are favorable towards a specific object. In our search of the literature, the definitions have been few and far between, and people have not really gone out on a limb, but we decided to couch our work within these definitions. So despite the blurriness of the concept, what kind of things might influence acceptability of certain interventions? And so if we think about built and policy interventions that are aimed at physical activity and healthy eating, the degree of awareness of the public health issue seems to be associated with acceptability, with people who have a better understanding of some of the issues being more acceptable of these types of environmental transformations. In our study, we focused a great deal on the issue of intrusiveness, That is, to what extent does implementing a given environmental intervention impose limitations on people's individual freedoms? And I'll come back to that in just a minute. Also, we can think about the degree and timing of implementation. Even though people may be resistant to a specific change early on, once the change is actually made and people have an opportunity to see how things might change, they may become either more favorable or less favorable to the change that has been done. There's some individual and social determinants, maybe sex or gender, that might be associated with, or some of the research suggests that it's associated with, and somewhat controversial research suggests that there are or there are not associations with social determinants. And more recently, people have examined the concept of whether desire for governmental support in addressing a specific issue might be a critical factor in terms of whether people find a change in environment to be acceptable or not acceptable. So let's turn to the issue of intrusiveness. Some of you around the table may be familiar with the Newfield Council on Bioethics intervention ladder, which I will illustrate here. And the suggestion around the Newfield Council for Bioethics is that there's a scale or a ladder or a staircase in terms of the intrusiveness of interventions. In public health, one of the least intrusive interventions is to conduct behavioral surveillance because it has no impact basically on limiting people's individual freedoms. People can, and public health can provide information, disseminating public service announcements, performing social marketing campaigns, which is a little bit more intrusive because it changes the informational environment. People can enable choice, such as, for example, building cycling lanes or sports facilities. People can change defaults, that is, for example, having salads instead of fries. When people are ordering a hamburger, the default option is to have fries, but we could change the default option and make it systematically being salads. Providing incentives such as tax breaks for active travel, vouchers for fitness and weight loss, implementing disincentives or extra charges for parking, for example, or entering the city, restricting choices such as banning junk foods from schools and workplaces. And finally, the most intrusive would be to eliminate choices, for example, to create car-free areas. And in fact, in public health, what we would like to be able to do is to have the least intrusive intervention that is going to have the impact on the health outcomes that we're aiming for. And if in fact we decide to choose something that's more or less intrusive than what is required to make the change that we want to change, the change that we'd like to achieve, is that we may have an issue of ethics and saying we should be doing a little bit more or something different to have the same kind of impact. Other people have characterized much more generally some of the level of intrusiveness as either carrots or sticks. And so we can think of eliminating choices, restriction, implementation of disincentives, and providing incentives perhaps as sticks, or maybe providing incentives is a carrot. And enabling choice, providing information, or doing nothing is much more like a carrot. So what we actually set out to do was we wanted to get a better sense of the prevalence of urban dwelling adults that reported high levels of acceptability of transformations that were aimed at the local food and active living environments. Because the survey was conducted during the first wave of the COVID-19 pandemic, what we did also was to add a certain number of items that related to accommodations to cityscapes that were made during the initial lockdowns. We also were interested in identifying differences across 17 census metropolitan areas, the 17 census metropolitan areas that are the largest ones in Canada and that regroup a very substantial portion of the Canadian population. And we were interested in identifying some social determinants that were associated with different levels of acceptability. So what we set out to do was to conduct a 20-minute survey of adults that were residing in one of the 17 census metropolitan areas. And at the individual level, we asked them to self-report the extent of agreement regarding the implementation of 45 different services, facilities, regulations, and policies if they had been implemented in their residential neighborhood, that is within a 15-minute walking distance or 8 to 10 city blocks. They were asked for each one of these, which I'll come to in just a minute, whether they completely agreed, somewhat disagreed, completely disagreed, or did not know or did not want to answer. 12 of the items were on food environments, 26 on active living environments, and 7 on COVID-19 accommodations. For the population, what we did at the population level, we looked at the percentage of individuals in different areas or different groups of social determinants that completely agreed or completely and somewhat agreed with an ensemble of items, either the ensemble of food environment items or active living environment items or COVID-19 accommodations. About 85% of people responded online, 15% responded by telephone. And to make sure that we had the most representative estimation of prevalences, we applied weights to our survey. We adjusted for age, sex, and education distribution in each one of the CMAs, which are different across the country. And we did a second adjustment to reflect the size of the population in the census metropolitan area versus the ensemble of 17 census metropolitan areas. Then we did proportional meta-analysis using the CMA adjusted weights, followed by meta-regression, which I'll speak to in just a few minutes. In total, we recruited just over 27,000 people, and the number of people recruited in each one of these census metropolitan areas appears on the left side of this slide. And what you can see is that we were aiming for about 1,200 individuals across most of the census metropolitan areas, but we sampled larger numbers of individuals in Vancouver, Toronto, and Montreal because the population base in those particular census metropolitan areas is larger. I'm going to go through the different items. And so what we have illustrated here is the Newfield Council for Bioethics intrusiveness ladder. And these are the items for food environments. We asked people about their level of agreement for holding newspaper, radio, social media campaigns to promote healthy eating, if that was implemented in their neighborhood. Modifying zoning laws to allow for the creation of new stores selling healthy foods, offering more urban spaces for community gardens and urban agriculture, changing the usual side dish in restaurants for a healthier option like salad instead of fries, creating public markets or farmers markets, supporting local and sustainable food production by creating gardens on the roofs of buildings. We also asked about imposing municipal regulations to limit fast food outlets around schools, eliminating the offer of chips, candy, and other unhealthy foods in restaurants, cafeterias, and vending machines in municipal buildings like arenas and recreation centers, providing money to purchase healthy foods like fruits and vegetables, imposing a tax on sugar-sweetened beverages, organizing activities demonstrating how to start a vegetable garden, limiting the size of sugar-sweetened beverages sold in municipal buildings like arenas and recreation centers. And so those were the food environment items. For the active living environment items, we asked our respondents about educating motor vehicle drivers on proper road sharing behaviors, broadcasting public information messages on active transportation, improving access to public transportation, improving greenness by planting trees and flowers, developing safer streets intersections by increasing the number of curb extensions, building protected bicycle infrastructures like separated bike lanes, reducing automobile speed limits to maximum of 30 kilometers an hour in the vicinity of schools, implementing a speed limit of 40 kilometers an hour throughout the city, improving public transit infrastructure, increasing the number of reserved bus lanes, developing new parks, adding road tolls to enter the downtown area, increase police surveillance and enforcement to have motor vehicle drivers obey traffic laws, increase the cost of fines for infractions to traffic laws by motor vehicle drivers, and the same too for bicyclists that do not obey traffic laws and bicyclists who commit infractions to traffic laws. We also looked at implementing traffic calming measures like making streets more narrow and adding speed bumps, closing off entire street segments to motor vehicles. Also, improving play infrastructures and rest areas in parks, increasing the number of priority traffic lights for buses, banning motor vehicles from circulating in front of schools when students are entering or leaving school, banning heavy vehicles from urban centers overnight, redistributing road space to make more room for pedestrian cyclists, to improve accessibility to parks and green space, by reducing cost of parking, improving accessibility to parks and green space by reducing cost of public transit to these specific destinations, develop safer street sections by increasing crossing time. And those were the active living items. For COVID-19 accommodations, we asked the following questions about communicating information related to respecting physical distancing when using green space in parks, installing disinfectant dispensers close to play equipment in parks, cleaning benches and play equipment in parks, providing access to public restrooms while requiring people to maintain physical distancing, modifying the layout of urban furniture in parks and to facilitate physical distancing, delimiting perimeters of utilization to create family bubbles in parks, and modifying the rules of use of parks, green space to facilitate physical distancing. Before I go to the findings, I just wanted to say I did read through these 45, so that may have been a little bit tedious for people listening. But I'd like to mention that when we tried to identify the items in the to be included in the questionnaire, we actually inventoried the different types of changes to built policy and social environments that were actually available in the literature and on some websites. And we had a list of close to 150 of these, and we did a Delphi procedure to identify the items that might be most relevant in terms of public health on the one hand, but also that we would have items that would go all along the intrusiveness ladder. Also, I would like to say that the order in which the different respondents read these different items was randomized across participants. So let's go to some of the findings at this point. And so in terms of the findings, what we have here in orange are the ensemble of food environment items. The green is for the active living environment, and the blue is for COVID-19 accommodations. What we see on the left three bars are the proportion of the population who completely agree. In the second set of three bars, we see those who either agree or completely agree or somewhat agree. In the third set of bars, it's those that completely disagree or somewhat disagree. And on the complete right-hand side, it's those who completely disagree. This is a bit unusual, but in looking at the findings, this is what people asked us to talk about. And so what we observe here is, in essence, the proportion of people who say that they're either completely in agreement or somewhat in agreement is actually quite high. And about 30 to 35% of the population say that they completely agree with the changes across all three sets of items. What I'd like to do now is that I'd like to present some of this information separately for each one of the different categories of food, active living, and COVID-19 accommodations. And here, again, what we have is in the first set of four bars, those that completely agree in the dark orange, those that either completely agree or somewhat agree. In the third bar here, those that completely or somewhat disagree. And on the right, the fourth one, which is those who completely disagree. And so what we did here is that we're illustrating what's going on for the items that were relevant that could be categorized as either information, enablement, changing defaults, incentives, disincentives, restriction, or elimination. So we were trying to get a better sense of what was going on with the level of intrusiveness. And what we observe here is that the least intrusive types of intervention, that is information and enablement, were essentially much more acceptable than those that are viewed as more intrusive, that is elimination or restriction of different possibilities, which is what we would have hypothesized. One of the surprises that we had is that we observed that even though in the initial conceptualization of intrusiveness, that changing the default was viewed as less intrusive than providing incentives, in terms of acceptability, we find that there's actually a dip here, that the changing of the default is viewed as actually more intrusive than receiving incentives for changes in the food environment. Turning now to the active living environment, we find that the gap between the minimum and maximum is 17% on complete agreement. And so again, we see this effect of intrusiveness with about 40% of individuals saying that information type interventions for active living environment, they're in complete agreement. But if we talk about eliminating or closures, we go down to hello?
Oh, sorry about that. I was on mute.
Oh, sorry. No worries. No worries. I thought that there was something that people were not hearing just now. So glad that there's still some people around listening. And so what we find here is that for the more intrusive interventions, that the level of acceptability is much lower. If we turn now to COVID-19 accommodations, we see the same type of pattern, which enablement and information is viewed as quite acceptable at around 40%, but interventions that involve restriction are viewed far less favorably and are viewed as less acceptable. Another question that people might be asking is that we did have 17 census metropolitan areas that we examined, and people are saying, well, is it in this city that people find this type of intervention more acceptable, and this city that they find it less acceptable? What we have illustrated here are for the ensemble of food environment items, the differences across the census metropolitan areas. These are census metropolitan areas and not cities, so they're much larger. The first bar is the estimate for the Canadian, overall Canadian estimate, which is here at about 35% of people saying that they completely agree with the ensemble of food environment items. And we do see a little bit of variation, with the lowest levels of acceptability being in the Calgary, Edmonton, and we'll see a little bit later, maybe in the Regina aspect, so in some of the prairies being lower. But what's really important to notice here is that the differences across census metropolitan areas are not as stark as the differences as a function of intrusiveness, which are really, really very, very significant. We can come back to that in just a minute. We observe something similar also for the active living environment, where the Canadian average for the ensemble of these items is just above 30%. And you see a little bit of a dip, Calgary, Edmonton, Saskatoon, and Regina, higher levels in central Canada, a little bit lower in Quebec City, but not substantially so, because you've got the 95% confidence intervals here as well. And then finally, for COVID-19 accommodations, what we see is that values hover above and below the national average, with this little bit of a dip in the Calgary, Edmonton, Saskatoon, and Regina census metropolitan areas. In terms of the regional differences, there were somewhat lower values in the prairies, as I mentioned, and because we regrouped them in terms of the British Columbia, the census metropolitan areas in British Columbia versus the prairies versus Ontario versus Quebec and Atlantic Canada. There's a bit of a lower level, but it's actually quite a bit smaller than what we observed for intrusiveness. We see the same thing for active living environments, or interventions on active living environments, and also for COVID-19 accommodations. Turning now to sex differences, we examined whether there were differences between men and women in terms of the likelihood of being in complete agreement with the ensemble of food environment, active living environments, and COVID-19 accommodations. And what we see is that there are actually quite substantial differences with men and women, with women being much more likely to say that they're in complete agreement with the environmental changes related to food environments, so hovering around 36 or 37%, with men at about 30% saying that they're in complete agreement. differences are present, but a little bit smaller for active living environments, and quite big with regard to COVID-19 accommodations, with women being much more likely to say that they're in complete agreement. If we also asked individuals using the questions that are used in the census, whether people identify themselves as being Indigenous, and we found that individuals who identify themselves as being Indigenous were like women, they were more likely to be in complete agreement with the food, active living, and COVID-19 environment changes that were listed across the 45 items. We found some differences in terms of country of origin. We asked people if they were born in Canada, or whether if they were born outside of Canada, if they were born in a lower middle income country or in a higher middle income country. And that was done by basically asking what country people were born in. And what we found was that there were not very stark differences, except for COVID-19, where individuals who were from middle income countries were more likely to say they were in complete agreement with these accommodations, in comparison to people who said that they were born in Canada. There was a bit of a difference for people from middle income countries to report higher likelihood of acceptability for active living environments, and a bit of a difference with food environments, but no systematic differences that as systematic as we observed for sex and for people identifying as being Indigenous. For education, the differences were actually quite small. If we look at COVID-19 accommodations, people with a high school education or less were a little bit more likely to say that they were in complete agreement. For food environments, it was the flip side. We found that individuals who had a university education were a little bit more likely to say that they agreed with the ensemble of food environment items. And for active living, the differences were very, very difficult to see in a systematic way. For all environments, we had thought that there might be differences based on existing literature with younger people showing more or less support, but for different types of environmental changes, but we didn't find any systematic differences across the age groups 18 to 34 versus 35 to 64 and 65 years and over. For income, the differences were also smaller, but largest for the COVID-19 accommodations, with individuals with an income of $40,000 a year or less being much more likely to say that they were in complete agreement with the accommodations that were made, and people with higher income, $120,000 a year or more, saying that they're a little bit less likely for the COVID-19 accommodations and for active living environments. And so I'd just like to, before we turn to some of the questions that we'd like to hear from you, as well as any other perspectives that you had, we'd like to say that we've had this far a total of 7 webinars with individuals who work in public health to share some of these findings on the one hand, but also to collect people's perspectives on the utility or relevance of this type of information. And we decided to do this work to disseminate the findings at approximately the same time as we were publishing in the scientific literature, because we believe that the content is novel enough that we wanted people to be aware of it, and that they have a chance to think about it before somebody might ask them about the relevance of this thing. This type of work. And so some of the questions that we'd like to hear from you, in addition to any questions that you might have, is what findings resonate with you and why, and what kinds of questions and issues do these findings raise, and how might these findings be useful in public health or not be useful in public health. So thank you very much for your attention, and I will now stop the presentation as well as the screen share so that we can get into a conversation.